Good afternoon and welcome to Bariatric Friday. This is United TV. My name is Kemal Erkan. Our weekly event, I'm going to have Dr. Irgau joining me. And Dr. Irgau, how are you doing?
I'm doing great. Kemal, how are you today?
I am doing great.
You still have energy after that previous session?
I have a lot of energy. So, it's a fun event.
It was very, very informative.
It's something that we do every day, and it makes it easier. So then, it's part of what we do every day, right? So today we are going to discuss the reason patients dropping out from the bariatric program. So why we discuss this is because there are several different reasons, but we want to kind of address certain issues and then see if we can address some of them here in this event. As we know that there are different reasons happening for different time and different motivations, and our goal is to make sure that we can be there for those patients who are going through these issues. So Dr. Irgau, if you would like to start, that would be great.
Absolutely. So what we're talking about essentially is that, patients come for a consultation for bariatric surgery. It is a decision, obviously, that is not taken lightly. They generally would have struggled for years, often with obesity, which is really a chronic disease. And, as they attempt different ways to try to lose weight, they find themselves not only back in square one after years, but also with much higher weight and perhaps having developed illnesses that require more and more medications. They come to realize that weight loss surgery really is a very important treatment for them, and they come to us. We do a consultation, and of course, we refer them for that preparation period that we've talked about in this platform many times, which is referring patients to nutrition, to psychology, to other practitioners, to medically as well as emotionally and mentally prepare them not only for the surgery, but also for life after surgery. And that does take time. It does require appointments. And what is seen very often is that patients do not complete that. They drop out from the process. Now, if we were talking about, dropping out from a class or other things, it's something, but we're talking about dropping out from a vitally important treatment process, right? Just imagine if you were a cancer treating Dr. Kemal, and you had patients that you're preparing to do cancer treatment, and these patients drop out from your list, you would be horrified, right? Because that cancer is going to get worse as the patients are not getting the treatment. So from our point of view as healthcare, providers, we take this extremely seriously, because here we have an opportunity to really treat this very serious chronic illness, and yet we're not able to take the patients through the process completely. Thankfully, we have in place a program here at the American Surgery Center and at CHRIAS, where really the dropout rate actually compared to what the national figures are is actually very low. And I'm extremely proud to be associated with this program, which does really a fantastic job in shepherding patients through the process and making sure that as many of them as possible actually complete the preparation and get the ultimate treatment. But we do still see dropout rates, and it's important for us to discuss that. So what are the barriers? And of course, we look at this time and time again. And today, obviously, we want to discuss this and try to see what those issues are and what our program is doing to address this.
So before we go into specific reasons, so the national average of the dropout rate ratio is about 55% in any other bariatric programs. So we were able to build a very solid, strong program here in American Surgery Center, and our patients, 73% of the patients, they complete the process. So it seems like we were able to address this issue to a point, but there's still some patients, that 27%, who starts the process and not able to go through. So those are the ones that we are going to discuss.
Yes. Now, clearly, if the dropout reason was because a patient found an alternative, treatment that, they have found successful, we're all for it, right? We're very happy for that. But in the vast majority of times, that's not the case. And we know that. We know it come out because the patients come back. They come back a year, 2 years, 3 years later, but now they are in a worse situation because the weight has gone up, they have aged, but also they've added comorbidities that are going to make their journey even more difficult than what it was when they first started. And so looking at those reasons is very important. Of course, part of the reasoning may be, personal readiness, right? Mentally and emotionally, are the patients ready to go through this? And it's not an easy decision. It's not an easy decision because of a number of factors. One of them is obviously clearly the fact that obesity is loaded with this societal stigma that makes patients feel guilty about it rather than look at it as a disease. And that guilt expands to the solution as well. Why am I not able to take care of this myself? Why do I have to have surgery to be able to do this? Should it not be an easy thing for me to lose weight, as if it was all based on willpower, right? But it is not. It is a biologically driven disease. We can talk all day long about the contribution of the environment, but the environment is where we are. This is where we live, and environment and biology are what they drive pathophysiology in any disease. So that cannot be any different with obesity. But clearly, because obesity has been targeted with this stigma, patients struggle with this idea that, oh, I should have been able to do it myself. And therefore, going to ask for help and ask help that requires surgery, sometimes they struggle with that decision. So that emotional and mental readiness is a recurrent theme through their decision process. And we know that also, Kamal, because when we ask patients, when did they decide to come for bariatric surgery, they tell us that actually it has taken them long. On average, in fact, bariatric patients take up to 2 years to come forward asking for a consultation. The first time they actually hear about bariatric surgery or learn about bariatric surgery, either through the media or through a friend or a family member that has had it, they reject that idea as something that is not for them, that they themselves are different and they will be able to do it by themselves. And that idea persists, and it's obviously influenced by the issues that I was mentioning earlier on, but it takes them up to 2 years to make that decision, right? So there is that struggle. But even after that, as they go through the process, they start second guessing, right? The other issue might be how will they cope after surgery, right? Their relationship with food, their ability to withstand the commitment that is needed, the life changes that occur. So these are naturally human, feelings where we can, obviously, we can play a major role in, right? Because we can support them, we can educate them, we can empathize with them. How? Well, through sessions like this, through the consultation process they will have with the surgeon, but also by providing other platforms that we have, like the support group, where they will be able to really exchange ideas with people who have struggled similarly. So this idea of mental and psychological readiness is very prominent in the decision of whether to proceed or not very often.
So that's kind of like the lack of maybe awareness of because one of the issues is that risk and complications, that's concerns related to risk and complications is another big reason patients drop out. Now, when we started CHRIAS 22 years, almost 21, 22 years ago, and until 2018, this was an inpatient procedure. And since 2018, for vast majority of our patients, we are able to discharge our patients on the same day, 6 to 8 hours after their surgery. What that tells you that is that the complication and risk factors are not what the perception may be out there for those. So it's a very straightforward procedure because of the things that we are doing pre-surgical and how we are managing a patient from the consult to the surgical time. Earlier session today, we have patients with diabetes who are going through the surgery, and Dr. George Ibrahim, in one of his slides, he mentioned that 95% of the work is done pre-surgical. So this is the same thing. So we're not going to put anyone at risk if they're not ready for the surgery. Even if they're mentally ready, if clinically they're not ready, we won't actually let them go through that. So that's one of the things that patient needs to understand. The other reason that I see, and I think this is maybe coming up more and more these days, Dr. Ergau, financial issues. Financial issues is maybe 5-6 years ago, it was a less of a problem. But today, there are two things. One is we now have inflation. So life is more expensive. And we understand why certain things may be a little bit more difficult to get. But the other thing with this is changing the insurance plans. So these high deductible, high co-insurance, high co-pay insurance plans are not also helping, because on one hand, we are talking about inflation. On the other hand, we are saying that patient now may have more out-of-pocket expenses. So that makes one makes the other one more difficult. So then that's why we probably need to also kind of see what patients' insurance plans are doing. But even though it's maybe, I would say 5, 6, maybe 7%, but I see that as a problem even in our program. Now, what we know from Medicaid standpoint, if you are in Delaware market and if you are with health options or MaryHealth or Delaware First, there's no out-of-pocket cost. So most employer self-funded plans, they don't have much outstanding out-of-pocket costs. So there are some kind of like high deductible plans there maybe, but it's really not that much. So that's why we have a group of people who are actually checking the insurance eligibility to make sure that they are not going to end up with a big expense. Now,
Absolutely.
can we talk about the unrealistic expectations? You deal with the patients every day. Like what type of expectations that they are expecting and why that fails them?
So that's actually a very good point as well, right? So patients, obviously, once they make a decision that bariatric surgery is what is needed in their situation and they come to consultation, very often it is upon us to educate them what the process is and what the expectations are as well, right? So clearly, it's not a quick fix, right? There is no such thing as a quick fix when you're dealing with such a chronic disease like morbid obesity. What does that mean? It means that there has to be a period of preparation, but also even after the surgery, all the success that comes with commitment, right? So if somebody is looking, for instance, to have, all the weight loss without really changing lifestyle in terms of paying attention to healthy foods, in terms of being really moderate with alcohol consumption, in terms of quitting smoking if they were smoking before, in terms of engaging themselves in regular physical activity, if they don't think those things are part of the solution that we are actually proposing, then it will be a shock for them, right? Because they're saying, well, I'm coming to surgery because I didn't want to do all those things. Well, then that is the wrong approach. That is the kind of patient that we actually don't want to offer bariatric surgery. The kind of patient we want is the one which says, look, I've tried everything known to man, and I have failed. I'm a successful person in many other things, but when it comes to weight loss, I just throw my arms because I can't do it. And we tell them, you can't do it because it cannot be done. It's not just you. It's just the nature of the illness, right? But we tell them, when we are offering bariatric surgery, we don't want you to stop the focus that you had before in terms of choosing healthy foods, in terms of choosing water than other, sugary drinks, in terms of being active physically. Those things are part and parcel of a lifetime of commitment so that obesity never, ever becomes a problem for you, or the obesity-related problems don't ever come into your health, right? So that is important. But if patients are not prepared for that, if there is unrealistic expectation as to what will happen after surgery, obviously our proposal is going to be met with surprise and perhaps even withdrawing, right? The problem, however, is that they're back to where they were, right? Because it will not go away. The fact that you're not really looking at it from a long-term point of view does not take the problem away. The obesity persists. It is a chronic disease. It is relentless. And what is worse, it is progressive, which means that it is not even guaranteed that the weight will stay at that level. 2, 3, 4, 5 years later, the chances are the weight is going to be higher. The complications of obesity are going to be more severe and more numerous. And the situation is not going to be any better, it's just going to be worse. So we have to present that picture. So we're doing this surgery not to offer a quick weight loss to somebody who wants to be suddenly thin, although that is a welcome thought as well. You know, everybody is entitled to want to look good and feel happy about themselves. What we're saying is the reason that this is happening is because there is a disease process behind it, and we have to be able to tackle it in the right way by associating yourself with this setup, with this program, which will provide all the support necessary to take you through, to prepare for surgery, to take you through safely through the surgery, but also to help you succeed in the long term.
Yep. So we mentioned the support group earlier. Those who are going through our bariatric program or who were already part of the program, so you can go to our website and very easily you can register for 2 things. One, you can become a member of the Facebook bariatric group, support group, and the other one is our support webinars once a month on Tuesdays, first Tuesday of the month. Usually Dr. Gelvin runs those, so patients can actually join those events and they can actually interact on those. But I think the Facebook support group has a different dynamic, so then patients are able to talk to each other, and it's a private group, so we don't let other people, if they're not part of the program, we don't let them in. We do verify everyone, so it's a safe private group. Now, in terms of Dr. Irgau, one of the things that I'm actually looking at our own statistics. So 763 patients in the last 3 years didn't go through the program. At some point, they may have come back, but this is the initial reason for them. And there's this lack of communication where we closed, that's 18%. So there's about 137 patients out of 763. They decided to stop communicating with us. So, and then that's where we mark them, okay, so lack of communication. So those patients, I think I have more concerns with them. It's almost, in a way, it's almost like a kind of, so just a lack of term that I'm going to use, like being, you know, sometimes we can be a little bit passive aggressive, meaning that we stop communicating, we shut down, but then there's issues, but we don't want to actually deal with that problem. So rather what we do is, let's say if I'm upset with you, and then instead of just telling you what it is, I stop answering your calls or messages. So, and then you don't even know what's happening, right? So I see it, I'm just using an analogy here. So I see with patients where we know that we can actually help them because there are several issues. They may be having these issues because one of them is, this week it happened a couple of times, patients who came back, one of them was Spanish speaker, didn't speak any English. So called my direct line in the office because it's on our communication emails. So I think that's how they find my phone number. So, but I was able to pull someone from the office who speaks Spanish, and this patient we did close for the lack of communication about a month ago. Now she wants to come back, and understanding how much this is for them, like it can be overwhelming. Now we do this every day. It seems like it's kind of easier for us because we know that it's going to be fine, but they don't know that. But what I would tell those patients is instead of taking that no action status, just tell us what the problem is. So even if you are not ready mentally, just tell us what that is. So then, because staying in the program, even if you don't go through the entire thing, it's still better than not communicating and not participating in the program. So that's one of the things that I wanted to address with our
absolutely. I mean, I think that is actually a it may also be a reflection of the complexity of the preparation process, right, Kamal, if you think about it, right? Now, when we are proposing this intricate, preparation process that requires consultation with different specialists, checking blood work, doing a chest X-ray, doing endoscopy, getting a cardiologist involved, it's not really to present barriers for patients to see whether they can overcome them as if that was a rite to passage. Far from it. What we know, Kamal, is, and we have absolute data on this, is that a multidisciplinary approach and preparation is results in much better outcomes in the long term, right? So if we were just in the business of just doing as many surgeries as we want, come on, we would be having patients just come in, schedule them, 2 weeks later for surgery and do it. But that's not the right way of doing it, because we're not interested in just doing the surgery. We're interested in curing a disease. That's really our focus. And we have to do what is being proven to work in the long term. And that is if you prepare patients appropriately by having an evaluation and education process before the surgery that engages different specialties to help the patient, then you will have better outcomes. But this by itself obviously sometimes is onerous, from a logistical point of view, from a financial point of view, from a really understanding point of view. And that's where we have to come and increase our presence and our support as much as we can. Obviously, if we are not able to engage in this process with the patients, if that communication is not there, obviously we're not going to be able to help. That is why that communication is very important,
Right.
just also to figure out why patients are struggling, right? So if they are not coming to the appointment, if they've done, for instance, 3 nutrition classes, they've seen the psychologist, they've seen the endoscopist, and then suddenly we don't see them, they don't show up for appointments, it's important for us to understand, because we may have ways to help them in the barriers that they are finding, right? If it is a concern about potential complication, about safety, that is a very reasonable concern. That's a very valid concern. And it's up to us really to demonstrate to them that bariatric surgery, because of the level of its scrutiny that it has gone through, has become one of the safest procedures that can be done in this country, right? When you compare the complexity of bariatric surgery and then the relative comparison of outcome, between bariatric surgery and something like gallbladder surgery or appendix surgery, sometimes you don't see any difference. So bariatric surgery has raised itself to levels of safety that are really unprecedented. It's become a very, very safe procedure. Nevertheless, it is still surgery. Although the rate of complications has gone down completely, it's not zero. So that concern is real and it's expected. But what we have to do is we have to be able to present them with the alternative and the risks of that alternative, right? So the risk of staying obese with type 2 diabetes, with high blood pressure, and the risk of early death are real. They've been proven from studies after studies, right? So how does
if you
that
don't do
compare?
anything, if you don't
Yes,
do anything,
yes,
it's not like we are going to be okay. So
yes,
there is a
yes.
cost, sometimes I call that opportunity cost. So not doing anything has an opportunity cost. That is how we live our lives today. So if this wasn't going to create any complications and we were going to be fine, okay, then don't do anything. But that's not the case. So there's a huge impact when you don't take an action. It's one of our topics that we discuss. This is a reason for life expectancy being shorter in many cases. This is a reason even for those patients who are going through the menopause earlier, right? So there's a lot of impact that's already there, other than looking good, being healthy, living longer. Um, from the sexual well-being, this is affecting every area of our lives, self-esteem, psychological issues, depression. So the cost is so high. The complication we address those complications, and we have a playlist on the channel so they can actually go there and watch, and then we are going to have another one coming up. But when you look at the complications, when you weigh the complications versus the cost of not doing it, that's just like so much there. So we have to take an action. Now, again, the thing what we did with our program is, and let's just take some credit, you and I, we both can take some credit for that.
Absolutely.
So, is that the support is there. So there's a designated nurse care manager, which not every program, for us, this is the main focus. For some bigger programs, they may have bigger fish to fry. But this is our biggest fish. So because of that, we put our full attention and full focus in bariatric. And there isn't anyone else in this country is doing this better than us. So I can just say that very comfortably. That's because, as I was saying this earlier, every day, like today, I spend a little over an hour with all nurses in a case conference, and that doesn't change every day. Every day is the same thing. So we have patients, now we know them by their name and their conditions because they've been discussed so many times. So now, with us, I know that they're not going to have those problems, but with other programs, they may. But the thing is, again, we want this to be not just like our program versus the others. This is about fighting morbid obesity as a disease. So it doesn't matter where you go, as long as you take an action, that's better than doing nothing. Now, of course, because this is a serious business, the reason I'm also so comfortable is because I have surgeons like Dr. Irgau, Dr. Bin, Dr. Peters, Dr. Singh, Dr. Ibrahim, who makes this extremely pleasant and safe so that I'm able to be a little bit more, not a little bit more, I'm very comfortable and confident. So, and also knowing our outcome, what complications we have, then there isn't really much. I mean, there isn't any, like, where there wasn't any, I mean, last time we kept someone overnight in the surgery center, it didn't happen in the last 12 months. I remember maybe 18 months ago. So that means we didn't have complications. Now, that's because we prep the patient extremely well. So, and again, the earlier session was about pre-surgical action that we take, and that's all about it. So we have to be able to communicate well, and even this program itself is one of the support element of those patients who may be lost in between. So hopefully, we can make it clear we can make it clear for those who may have some issues with the process. Dr. Rao, one question I have, another question actually, in terms of the medical conditions, other medical conditions, how often do you see that with your patients, like because they have other unrelated complications to the bariatric surgery, but because of that they cannot have the surgery? Like how often that happens from your side?
Yeah, fortunately, it doesn't happen very often, and the reason it doesn't happen very often is because most of those conditions can be addressed in a timely fashion and do not interfere with the plans of surgery. But occasionally we do discover, issues that need to be addressed. And, sometimes one of the good things about this extensive evaluation is we actually find things that could be very harmful, but we find them in their early stage. And this could be like an early cancer, for instance, that we detect because we've done a chest X-ray and they had no symptoms about it, or because we've done endoscopy and we found a tumor, for instance, either in the food pipe or in the stomach that needs to be taken care of. Or we've done, other tests that led us to discover abnormalities that need to be addressed. So those obviously are the reason in part why we're doing all this preparation, but also it offers us an opportunity really for the patients to get care and then they can come back into the program. So the vast majority of times we're able to address them, whether it's an abnormal blood test or whether it's something we find in imaging, and then the patients actually stay on course within the time frame that we have allocated for the preparation. But sometimes they have to go get the treatment and then come back for bariatric surgery afterwards. So it doesn't happen all that often, but obviously it is something that we are prepared for because part of the reason we do all these tests, Kemal, is to make sure there is nothing that's being overlooked prior to bariatric surgery.
Exactly. All right. I think, again, I feel much better when we are here available for our patients, and especially knowing every day they may have different types of issues. Like I talked to one of the patients this week. She's like, "Oh, I just don't want to use the portal." I'm like, "Well, let's talk about it." So then, we set her up, and then she didn't have her password, and I spent a little bit of time with her, but at the end of the day, she just didn't want to do it because she didn't have her password, and she didn't want to. She just didn't want to do it. But then, because with our program, from the multidisciplinary standpoint, when you have access to our patient portal for CHRIAS, you have access to Delaware Cardiovascular, you have access to Hosmani Cardiology, you have access to United Medical Clinic, Surgery Center. Who else am I missing? Dr. Handal from Endo standpoint. So because all those are also in the same portal, patient actually has access to multiple practices with one login. So we experienced, and she was happy at the end of it. But I think we'll be able to do better if we are able to hear it directly from our patients. So that is kind of like the main thing. So we are here to help them. Support group, again, please go ahead and sign up for it. And there's a lot of good conversation happening, and hopefully we can do more and better for our patients. Dr. Irgau, thank you so much for joining me.
Thank you, Kemal.
We'll catch up again with you next week. We have another session coming up. But until then, please stay safe and have a great weekend.
Have a nice weekend, everybody. Thank you.